This is our presentation on Tourette syndrome for class Social Work 8115, DSM in Clinical Practice by Emily McMichael, Bailey DeShutter, and Dawn Aminsky. Tourette's disorder falls under the neurodevelopmental disorders in the DSM-5. Within the categories listed, Tourette's is found listed with the motor disorders under the tic disorder subsection, characterized by sudden, rapid, recurrent, non-rhythmic, stereotyped motor movements and vocalizations. Tourette's is found with other tic disorders that are characterized by their respective specifiers and features. Tourette's has always been included in the DSMs historically, though the language used to specify the disorder has changed over time, along with certain features. Previously, Tourette's was listed among other obsessive behaviors and disorders, but can now be found arranged with other neurodevelopmental disorders rather than those more associated with mental health. The first DSM was published in 1951 and listed the criteria for Tourette's among diagnostic criteria for echolalia, interjectional speech, habit spasms, spasm nutans, which is nodding of the head, and tics, irregular muscle contractions. It was also listed with other obsessive behaviors such as neurotic excoriations or skin picking, and trichotillomania, the obsession and compulsion to pull one's hair out. 1968 was the release of the second edition of the DSM, but did not list tics exclusively anywhere else. In 1980, the DSM-3 was published, and with it came the diagnostic criteria for Tourette's that we are most familiar with. The diagnostic criteria included age of onset between 2 to 15 years of age, a description of symptoms with variations in intensity that have lasted for more than 1 year. In 1987, the DSM-3 had a text revision that included language to identify whether symptoms were intermittent or if they happened together or separately. In 1994, the DSM-4 was published, and Tourette's listed the same specifiers as previous editions, but more specific language was used to clarify the duration of symptomatic behaviors. They included that through the year of consecutive presence of symptoms, there was never a tick-free period lasting longer than 3 months, meaning the symptoms came and went, but were never absent for longer than 3 months. In this edition and the text revision of 2000, the age of onset was changed from 2 to 15 years to before the age of 18. The DSM-5 is the most recent edition, having been published in 2013. It lists Tourette's among the neurodevelopmental disorders alongside intellectual disabilities, communication disorders, autistic spectrum disorders, and ADHD. It's included in the motor disorders and is listed as a tic disorder. And I did forget to mention that this slide was done by Dawn Aminsky. This slide, done by Dawn as well, is talking about the diagnostic criteria for Tourette's. So the diagnostic criteria for Tourette's disorder is persistent, chronic motor or vocal tic, with both tics present at some point, but not always occurring together. They may come and go, but have been persistent for more than 1 year. The age of onset is before 18, and they're not attributed to other factors like effects from substances or other medical conditions. While persistent and provisional tic disorders, with persistent tic disorders, only a single specifier is present with vocal, with motor, but not both. It can come and go like Tourette's. It has been attributed to other medical condition or effects from substances. It has never met the criteria for Tourette's. And for provisional tic disorders, they can have a single or multiple presentations, vocal and motor, for less than 1 year. As you can see on the infographic image of an iceberg, Tourette's motor and vocal tics are only on the surface. Below are many other conditions and issues the individual is experiencing. The right is a graph of children ages 6 to 17, and the red line represents those diagnosed with Tourette's and a co-occurring disorder, and the blue line represents just a singular disorder. As you can see, those who have some of the more commonly known childhood disorders, such as ADHD, obsessive compulsive disorder, etc., also have Tourette's. In the upper right-hand corner is a graphic that depicts the overlapping nature of these childhood disorders. Sleep problems, school problems, peer and social problems all overlap each other and create complexities within the diagnosis. This slide was done by Emily McMichael. While there are no specific tests that can be given to diagnose Tourette's, an accurate diagnosis can be made based off of the signs and symptoms. While some signs can mimic other conditions, tics are typically obvious and can lead to an accurate diagnosis. For an example, while squinting your eyes is a common tic, it can also be a symptom of vision issues. This video is a good case example of Tourette's. This slide was a collaborative effort between Emily and myself, Bailey. So these are the possible implications of Tourette's. Common difficulties people, especially young people with Tourette's, face include a lack of support from school staff, being bullied because of tics, trouble concentrating in class, and a loss of opportunities. There's actually a user on the social media app TikTok who self-reported that she went to school to be a kindergarten teacher, but she had to stop when her Tourette's was causing her to swear and use inappropriate language while she was student teaching. For positive implications, enhanced cognitive control, there was actually a research study done on the mechanism that helps children suppress tics and found the constant struggle led to a higher ability of the brain to process information and a higher level of adaptation. Verbal strengths tend to be more creative and are often more empathetic, energetic, and resilient. The slide was done by me. This is evidence-based intervention. The one that came up the most in my research was habit reversal training, which has three central components. The first component is awareness training, which is a focus on creating and building awareness to tics happening, what happens during the tic, and recognizing the urge before a tic. A competing response training is creating a behavior that's physically incompatible with a tic to implement when the client's able to recognize the urge before a tic. And social support reinforces the competing response by a support person being trained to help with awareness training and competing responses. Clients that received HRT experienced reduced tic frequency up to 18 months after the initial treatment phase. And there are different types of competing responses you can do, like instead of pulling hair, you ball your hand into a fist against the side of your body, or you rub your earlobe, you lick your lips instead of picking your lips. There are multiple different things that have been found to help. Evidence-based interventions continued. Medications can be used to reduce the severity or frequency of some of the more problematic tics people may have. It may take time to find medication that works best. It varies from person to person. Medications have been proven to reduce the severity of tics. Haldol, Pimozide, Risperdal, Prolixin, Clonidine, Tenex. Under that first section are antipsychotic medications. Less studied medications are Klonopin, Imbrucine, topiramate, and baclofen. And Klonopin is typically used as an anxiety medication. Topiramate is typically used for seizures, and baclofen is actually a muscle relaxer. And these were the references that we utilized for our presentation. So thank you for listening, and we hope you learned about Tourette's disorder, Tourette syndrome.